And we will get started in 1 to 2 minutes. Thank you for joining. So, good afternoon, everyone. Welcome to today's webinar on climate change and infectious diseases. My name is Sheri Weiser, and I'm a professor of medicine at UCSF and the co-founding director of the UC Center for Climate Health and Equity. And just to remind you, the mission of our center is to really harness that expertise and leadership of the health sector to drive ambitious climate action for health and health action for the climate. While our center is based at UCSF, it spans all 10 UC campuses and 5 health systems with over 100 affiliated faculty. And our webinar today is co-sponsored by our UC-wide Eco Health Center and the UCSF Academic Senate Committee on Sustainability. And this is the second webinar of our spring series on climate impacts across medical subspecialties, and we'll focus today on infectious diseases. To remind you, a recording of today's session will be available on our YouTube channel within a few weeks. You can all view past recordings of the link that is going to be put on in the chat right now. And with that, it is my pleasure to introduce today's speakers, Professor Alexandra Heaney and Dr. Abraar Karan. So Dr. Alexandra Heaney is an assistant professor at the School of Public Health and Human Longevity Science at the University of California, San Diego. As an environmental health scientist and climate epidemiologist, her research integrates epidemiology, computational science, and community engagement to explore how climate variability influences human health. Dr. Heaney leads interdisciplinary projects focused on climate-sensitive infectious diseases, including coccidioidomycosis, also known as valley fever, and the impacts of extreme heat, particulate dust, and wildfire smoke on adverse birth outcomes and healthcare utilization. Her work aims to inform public health interventions and develop early warning systems to mitigate disease risks associated with climate hazards. And then our second speaker is Dr. Abraar Karan, who's an infectious disease fellow and postdoctoral researcher in the Division of Infectious Diseases and Geographic Medicine at Stanford University, and will be starting on the faculty in July. He has worked on previous outbreak responses for COVID-19 and monkeypox, both with the Massachusetts and Los Angeles County Departments of Public Health. He's also contributed to the WHO Independent Panel on Pandemic Preparedness and served as a policy advisor for the Biden-Harris campaign on COVID-19 mitigation in schools. His current research includes studies on air filtration to reduce COVID-19 transmission in low-income homes, zoonotic spillover of Marburg virus in Kenya, and H5N1 surveillance in California. And please put any questions you may have into the Q&A function in the chat. And then before I turn it over to them, I'm just going to give a very brief presentation that will provide an overview of some of the pathways through which climate change affects infectious disease. And I'm just going to share my screen right now. And sorry, let me get this out of the way. So climate change, we know, has already increased the risk of over half of all known human infectious diseases. And this is because the ability of pathogens to survive and spread is really shaped by environmental conditions like temperature, precipitation, and humidity, but it's also shaped by population dynamics, such as the number and susceptibility of individuals and exposure opportunities that facilitate transmission. And we know that all of these factors are influenced by climate change. So let me go through some of the pathways through which climate change can increase exposure, spread, and susceptibility to infectious diseases. And importantly, these pathways are adapted from a previous conceptual framework our team developed, really looking at those pathways from climate change to HIV/AIDS, and we have been actually testing these pathways empirically in studies. So starting at the top of the figure is global environmental change, including things like rising greenhouse gases and temperatures, rising sea levels, natural disasters and flooding, among other things. And these ecologic drivers create 5 pathways that we've been testing through which climate change can affect infectious diseases. And these are water stress and contamination, migration and displacement, food insecurity, disrupted healthcare access, and vector host migration. So we know that these pathways in turn can increase the incidence of a range of different infectious diseases and also worsen health outcomes among those affected. And importantly, these pathways we know affect each other. So for instance, water and food insecurity we know can drive migration and displacement and also can lead to disrupted healthcare access. At the bottom, you can see that increased infectious disease, morbidity, and mortality then contributes to decreases in household resources and labor availability, which then can lead to further depletion of natural resources through things like deforestation, land degradation, and overfishing, which then perpetuates this vicious cycle towards worse local ecologic harm. And let me give you a few examples of these pathways. So starting with water stress, studies consistently show that people who live in drought conditions have a higher prevalence of HIV. So for example, one study that used demographic and health survey data, or DHS data, from 19 countries in sub-Saharan Africa found that each year of experiencing drought was associated with an 11% increase in the HIV/AIDS prevalence. And in our team, we looked at the converse and used DHS data from 23 countries in sub-Saharan Africa. And we found that each year of experiencing extreme precipitation was associated with 14% higher odds of HIV and 11% higher odds of another sexually transmitted infection. So turning to migration, we have found really important health impacts of climate-related migration, and we've also shown that there may be gender differences in climate-related displacement. So here's a recent analysis using DHS data from 23 countries in sub-Saharan Africa. And in adjusted analyses, Adrian Epstein on our team found that women had higher odds of migration in both conditions of drought and excessive rains, while there was no statistically significant associations for men. And this really has important public health implications because we know that female migrants face unique health challenges, including, for instance, exposure to gender-based violence. So the quote on the right-hand side is from a qualitative study led by Tamina Castro on our team in Kenya. And as you can see in the quote, floods were really viewed as a huge contributor to migration due to destroyed crops, homes, and infrastructure. So as an example of how climate change can affect food insecurity and nutrition, in a meta-analysis, Mark Lieber on our team found that drought conditions were associated with 46% higher odds of both wasting and underweight prevalence in adjusted analyses. And in a prediction model, he estimated that climate change will increase the prevalence of malnutrition by greater than 50% by the year 2050. And the quotes on the right-hand side are from the same qualitative study I just went over. And participants talked about how loss of crops, animals, and income from drought or flooding really contributed to food insecurity and worsened diet quality, and even contributed to weight loss and stunting in their children. And I'll just read the top quote here. So a 54-year-old woman says, "Weather changes affect yields on my farm. Too much rain or drought interfere with the growth of plants and lowers the quality of yields. This interferes with our children's growth since they are forced to eat food that are difficult to chew." Finally, as an example of disrupted healthcare access, Jason Nagata on our team used DHS data to look at the association between drought in the previous year and child vaccination coverage among 130,000 children born in 22 sub-Saharan African countries. And we found that drought was associated with lower odds of completion of 4 different childhood vaccinations, so BCG, DPT, polio, and measles, certainly an important pathway towards increased spread of those infections. So let me spend an extra minute or two covering the last pathway, namely that climate change we know alters the breeding patterns and geographic range of both insect and animal disease vectors. So generally speaking, we know that vectors tend to prefer a warmer world, since higher temperatures can really improve a pathogen's capacity to survive and spread. So rising temperatures, for instance, we know cause viruses to replicate much more quickly inside mosquito vectors. It also reduces incubation periods and lengthens those breeding seasons. Changing weather conditions, we know, also expand or at least shift the geographic range of vectors. And then this brings the pathogens into contact with either larger numbers of individuals or at least new populations that have not been previously exposed. And finally, those precipitation extremes, such as drought and flooding, we know increase the availability of standing water for mosquito breeding. And we also know that storm surges we've seen overwhelm sewage treatment plants and contaminate drinking water supplies. So just as an example, these maps show the current worldwide distribution of the Aedes aegypti mosquito that carries Zika virus and dengue fever, and how this distribution is projected to change under the year 2080 under current emission levels. And you can see that the mosquitoes are projected to move away from some areas, but then they're going to be moving into new areas that don't have existing immunity or public health infrastructure, which will contribute to higher morbidity and mortality. In California, we know that our prolonged dry seasons mean longer transmission for valley fever, which is also increased by wildfires, and Dr. Heaney will be speaking about this shortly. West Nile virus is also becoming much more of a concern. So a recent study, for instance, found a 5% increase in incidence with each 1 degree increase in temperature. Finally, with the changes in temperature, humidity, and the spatial distribution of host animals, it is actually predicted that a third of California's land area may become suitable to the ticks that are the primary vector for Lyme disease. So an estimated 75% of emerging infectious diseases in humans are zoonotic, and these are also influenced by climate change. So changing climate conditions like rising temperature and precipitation shifts, when you combine these with human actions, such as deforestation and urbanization, well, then this can shift the population density of those animal reservoirs of infectious diseases, bringing them into closer contact with both humans and their livestock, creating the perfect opportunity for viral spillover. Importantly, these conditions can also increase pathogen transmission by causing heightened physiologic stress in those animals. So this then reduces the animal's immune responses, leading to higher pathogen loads and viral mutations, and it's projected that climate change is going to be increasing the risk of global pandemics for the foreseeable future as a result of these mechanisms. And we're going to be learning about one example of this from Dr. Karan, who is going to be talking about Marburg virus, a zoonotic disease affected by climate change. And just before I turn it to our speakers, I just want to point out that there's a number of important gaps in climate change and infectious disease research to date. And I've summarized some of the biggest ones here, along with opportunities for the future. And so to highlight just two things here, most of the work thus far has looked at one disease type in one geographic area, but there's really been little multimodal global assessments to elucidate cascading risk pathways. And I know there's definitely some funded grants on this, and so we hope to see more of this in the future. There's also been a methodologic emphasis on quantitative exposures, much less of that mixed methods research with the qualitative components that can really give voice to those most impacted by climate change. So a recent systematic review found that most climate change and infectious disease research has really shown a topical bias towards vector-borne pathogens, and as you can see, particularly those transmitted from mosquitoes and ticks, but there's been much less on foodborne, waterborne, and airborne diseases, which is an important gap. The same systematic review found a regional bias in the climate change and infectious disease research, with more studies focused on the temperate areas, as you can see in dark blue in the figure, rather than in the tropical regions. And finally, there really is a lack of studies on mitigation and adaptation strategies. So a recent synthesis of evidence that used machine learning techniques found that climate change and health research is really dominated by impact studies, as you can see in the light blue in this figure, but much less attention on interventions to address these risks, as you can see in orange, and also very little on those mediating and moderating pathways that you can see colored in green. We'll hope that we'll get to some of these in the discussion. And on that note, I'm going to stop sharing, and I'm going to welcome Dr. Heaney to present and to share her screen.
Great, thank you so much. Let me share, make sure this looks okay. All right. Everything look okay with the screen?
Yes, everything looks great.
Okay, great. Well, thank you so much for that really fantastic introduction. I think it went over the very diverse ways in which climate change can impact infectious diseases. Today, I'm going to talk to you all about some of my work related to fungal diseases and climate and environmental drivers in California. So, in the past few years, the connections between climate change and fungal diseases have been increasingly discussed in the media. We've seen articles like this: expect more fungal infections as their geographic ranges expand. Warmer climate may drive fungi to be more dangerous to our health. Here's how climate change is pushing fungi closer to harming humans. And even in a popular HBO show, The Last of Us, which is about a zombie apocalypse that takes place 20 years after a global pandemic caused by a newly emerged fungal infection. But despite this increased media attention, our scientific understanding of the links between climate and fungal diseases actually is pretty limited still. Broadly, we think that climate change will influence the distribution and severity of fungal diseases by altering the diversity and abundance of human pathogenic fungi in the environment. Fungal pathogens are also thought to be adapting to warmer temperatures, which then can extend the range of fungal diseases beyond their historical geographical distributions. And that adaptation to heat can also lead to the emergence of fungal pathogens that are able to cause disease in human hosts. We also know that climate change is leading to the increased frequency and severity of extreme climate events like dust storms, hurricanes, floods, drought, and heat waves. And these extreme events can increase fungal disease risk by dispersing and aerosolizing fungal spores so people become infected, as well as leading to the inoculation of traumatic wounds with fungal spores. And lastly, the use of fungicides is increasing, which may accelerate the development of antifungal resistance. But there's still very large knowledge gaps in climate change epidemiology for fungal diseases. So we think that a lot of fungal diseases are likely climate sensitive, but rigorous research investigating these relationships remains pretty limited. So today I'm going to talk to you about one example of these emerging fungal diseases called coccidioidomycosis, also called valley fever, which is much easier to pronounce. Valley fever is a fungal respiratory infection that causes flu-like symptoms, like the ones you can see to the right here, including fever, headache, cough, shortness of breath, chest pain, muscle pain, and joint pain. We think that about 60% of infections are asymptomatic, and that most of the symptomatic cases are actually self-limiting, meaning patients are able to recover on their own. But 5 to 10% of the symptomatic cases can actually develop serious long-term lung problems, and 1% can develop what we call disseminated disease, which is when the infection spreads from the lungs into other parts of the body, such as the central nervous system, like the brain, the spinal cord, the skin, the bones, or the joints, and that disseminated disease can oftentimes be fatal. So transmission occurs through the inhalation of aerosolized fungal spores. These coccidioides spores live in the soil where they proliferate and grow. And once they've fully matured, they break apart into smaller infectious spores, which can then become aerosolized. And when they're aerosolized, people can inhale them, which can lead to infection and disease. You can see on the right here a map that shows that valley fever is endemic to the southwestern area of the United States, which is typically hot and dry. But we also think that this geographic range is likely expanding. So in California specifically, the majority of cases are reported from counties in the southern San Joaquin Valley, which is where the name valley fever comes from. But we're seeing increases in numbers of cases in the northern parts of the San Joaquin Valley and along the central and southern coast. So you can see some of those counties outlined in black here in California. And valley fever is of increasing concern in California because cases have increased dramatically over the past 2 decades, with over a 600% increase in annual cases from 2001 to 2023. And when we look at the trends in cases over time, we can see that cases are increasing relatively steadily in some of these areas that have traditionally higher rates of disease, like Kern County, highlighted here in red. But we see that the rates of increase are actually much higher in the coastal regions and in the Northern Valley regions, where incidence of disease was historically low. So you can see here at the bottom, this is a plot of cases in Monterey County highlighted, which are historically quite low, but in the recent years have been increasing quite dramatically. So these trends have all led us and many others to ask what factors are driving these increases in cases and in the geographic distribution of valley fever across California. And thanks to our work and the work of many other fantastic researchers, we are all pretty sure at this point that climate variability and climate change is playing an important role in this increase and expansion, which has garnered significant news coverage over the past several years. So the relationship between climate conditions and valley fever is directly related to the life cycle of the fungus in the soil. So wet conditions supply the necessary nutrients and moisture for the fungus in the soil to grow and develop into its infectious form. Then hot and dry conditions are necessary for the release and the dispersion of infectious spores, which then people can inhale and can make them infected. So on the left at the top here, we're now seeing the average proportion of cases in each month across California from March to February, because that's what we think of as the transmission year. And what we can see here is that the peak of cases on average occurs between September and December. Below now, we have plots of the average monthly temperature and average precipitation across California counties. We can see that the peak in cases occurs on average at the end of the summer dry season and before the winter rainy season. So in a paper led by my fantastic colleague, Dr. Jennifer Head, who's an assistant professor at University of Michigan now, we investigated the lagged associations between temperature and precipitation with incidence rates of valley fever. Our results showed that increased precipitation in the winter season was associated with more cases of valley fever in the fall season. And specifically, we found that an increase of 1 interquartile range in winter and spring rainfall was associated with about a 45% increase in incidence of disease during the fall season. We also found that hot, dry summers were associated with increased cases in the fall. Specifically, 1 IQR increase in summer temperature was associated with a doubling of incidence in the fall. So in addition to these within-year shifts between wet and dry conditions being important for driving disease risk, we've also found that multi-year drought conditions can enhance risk for disease. So here I'm showing you a plot of monthly cases of disease from 2000 to 2022 in California. So our work found through a couple different papers that are both cited here that droughts actually suppress risk of disease with fewer than expected reported cases during droughts. And that's shown here. The drought periods are shown in the yellow color in this plot. But we found that when heavy rains return, so rainy conditions follow a long drought, we see larger than expected cases, spikes in cases. And this is shown in these red peaks we can see here in cases after these long drought periods. Now, in brief, we think that these multi-year shifts between dry and wet conditions influence some of these upstream factors, such as rodent populations, land use changes, and other abiotic and biotic factors that are important for coccidioides growth. So after establishing these relationships between valley fever and climate conditions, as many of you who live in California know, there was a very extreme drought that occurred from 2020 to 2022. At the top here, so we're seeing the same plot of cases at the bottom that we were just looking at. At the top, I'm now putting a plot of the US drought monitor information, which shows severe drought conditions in the darker red colors over time. You can see here one of our colleagues, Simon Campanuri, who also has led a lot of this great work, sampling some soil for one of our other projects in a field site in the Carrizo Plain during this time, and it was quite dry. So this drought was then followed up by a really heavy precipitation during winter of 2022 to 2023, where statewide precipitation was actually 150% of the average, and that was even higher in some of the endemic regions for valley fever in the state. And this is that same field site you're looking at here following those heavy rains. So a pretty significant shift in what this landscape looks like going from that drought period to a period of heavy rainfall. And based on our prior findings, this extreme drought followed by heavy rainfall led to a lot of concern about another spike in valley fever cases. So in response, our colleagues at the California Department of Public Health put out a press release in August 2023 that warned of potential increased risk. And here's a quote from that press release saying, health officials urge caution as high rainfall this past winter could lead to an increase in valley fever cases across California. And unfortunately, but as expected, the state did see a near record number of cases in 2023, shown in the blue box here. But these wet conditions then continued into the winter of 2023 and 2024, with precipitation again above average, about 115% above average that year. And that made us wonder, what will 2024 and 2025 bring in terms of the number of valley fever cases we might see across the state? And more specifically, we wanted to see if we could use the relationships that we established between climate and valley fever to enhance some of these early warnings that our California Department of Public Health colleagues were putting out. Can we do better than just saying, we think it's a good idea, we think it's going to be a risky year for valley fever, and produce a more quantitative outlook on what the coming months might look like? So in work, again, led by the wonderful Simon Campanuri, who is finishing his PhD at UC Berkeley right now, we developed an ensemble model to forecast cases of valley fever based on climate information. So first, we fit the model to the past cases that were observed, which are shown here in these black dots. And the blue line represents our model fit to these observed cases with a 95% prediction interval. We then used that fitted model to forecast future monthly incidents of disease from 2023 through 2025. Our forecasts are shown here in purple with a 95% prediction interval, and preliminary case reports from the California Department of Public Health are shown here in black X's. So comparing our forecast to what we observed, we see that the forecast actually really closely matched the spikes in 2023 and 2024 cases. The forecast cases did start to increase a little bit before we see an increase in the provisional case counts, but the magnitude of the increase was very similar to what we observed. And so far for the data we have in the 2024 season, our forecast has matched monthly statewide reports quite closely. So, in response to this, our partners at California Department of Public Health then published another press release warning of the increased risk of valley fever in 2024, identifying specific regions where risk might expected to be worse, which also came from our paper. I don't have time to show you those regional results. And importantly, providing information on how to reduce the risk of being exposed to the fungus. Some examples of that are to stay indoors and keep windows and doors closed. If you're driving through a dusty area, keep your car doors closed and use recirculated air. If you do have to dig in the soil, wet it down first to prevent stirring up dust. And consider wearing a properly fitted N95 mask respirator if you have to be in dusty areas. So just to finish up, putting this work in a larger context, climate projections indicate that droughts are becoming more frequent in the southwestern US as high temperatures are co-occurring with precipitation deficits more regularly. Precipitation is also expected to become more volatile in California, meaning that these swings from really dry to really wet conditions will become more frequent. And we think that this may pose risk for increasing valley fever cases continuing into the future. So very quickly, some key takeaways. The seasonal and year-to-year swings between dry and wet conditions create high valley fever risk. Climate-based forecasting models can accurately predict near-term disease patterns, and we need to prepare for a more volatile future climate. I can talk a lot more about this in the Q&A, and I invite questions about this. But just to finish up here, how do we do this? Well, I think the key is to develop tools that can regularly be used by healthcare and by public health and healthcare professionals, all with the goal of building resilience to climate-driven fungal disease risk in vulnerable communities. So with that, I will stop and thank all of my wonderful collaborators without whom none of this work could be possible. And thanks again for having me. I look forward to some questions.
Thank you so much, Dr. Heaney, for that excellent presentation. And it's my pleasure now to bring on Dr. Abraar Karan.
Great. Thanks so much for having me. I'm going to pull up my slides here as well. Great. So I'll be speaking today about Marburg virus. So I'll take you from California across the globe to sub-Saharan Africa, where we are conducting work on Marburg virus exposure in Mount Elgon, Kenya. So just some brief epidemiology on Marburg virus. The virus is a filovirus similar to Ebola virus found in sub-Saharan Africa. The map on the right of the screen here shows a number of outbreaks that have occurred over the years. As you can see, most of them are in East Africa, with some in West Africa as well, and some in South Africa. The virus usually causes a hemorrhagic fever in humans, and the transmission is primarily from the reservoir host, the Egyptian russet bat, through urine, feces, saliva, or birthing fluids, and it can be transmitted by many routes, including through fomites when an object gets infected, through aerosols, or through direct contact with any of the excretions mentioned. The transmission primarily between humans occurs through bodily fluid exposure and close contact. And 14 outbreaks have occurred from 1967 to 2025. Some of the notable ones: Angola was the largest outbreak, 252 cases and 227 deaths in 2004, with a very high case fatality rate, as you can see. Colorado, this was a single case of a return traveler, and we'll talk a little bit more about this one, from Uganda back to the United States. And in Rwanda, recently, we had a large outbreak in healthcare workers across healthcare facilities, but with a much lower case fatality rate of 15 deaths out of 66 cases. So surveys that look at antibodies have shown that people can be exposed to Marburg virus without developing hemorrhagic fever. And this has been seen in certain populations, such as mine workers, who are deep in caves where these Egyptian russet bat colonies tend to be. And also people who actually don't have risk factors at all, where surveys were done in populations that live near areas that have had outbreaks where they detected antibodies in some people. And also in animals that are not the reservoir host, so also in livestock and in dogs. So this tells us that there is more spread of the virus than we know of. It doesn't always lead to hemorrhagic fever, but the extent and the reasons why it may not be causing severe disease are yet to be fully understood. So what does this have to do with climate? What does this have to do with the way things are changing globally? So what we can see at 50,000 foot view is that outbreaks may be increasing. From 67 to 99, there were 5 outbreaks over 32 years. So that's every 6 years. From 2000 to 2019, there were 6 over 20 years, so about every 3.5 years. 2020 to 2025, there were 6 outbreaks over 5 years, and in new countries that had never had Marburg virus outbreaks before: Guinea, Rwanda, Tanzania, Equatorial Guinea, and Ghana. Now, this may be because there's better detection, more access to PCR testing in more areas that didn't have it before, in clinics and in cities. And so maybe we're just detecting more. But could it also be that there's actually more spread happening from the reservoir host into human populations? So this is a UC focused talk. So one may say, why does this matter here in California? Talk about Marburg virus disease all the way over in East Africa. Well, I think as has become very apparent, the risk of rapid disease spread via international travel is something that has totally changed the dynamics of what can become a pandemic from an epidemic. So we see a lot of transmission in planes and airports. We see that frontline diagnostics here in the United States are not well positioned to identify zebras. When we had an importation of Ebola during the outbreak in West Africa to Dallas, the case went missed. And so we have a high risk of things being imported and transmitting rapidly and not being diagnosed quickly. For many of the filoviruses, we don't have effective treatments. We don't have fully approved vaccines for Marburg virus. And I have worked on 2 outbreak responses in the US now, both for Massachusetts Health Department and for LA County Health Department. And while we do a good job in certain aspects, I would say broadly across the whole country, our outbreak response is still catching up. We're often left kind of catching up to where the disease is. And we have a fully susceptible population here. People are not getting vaccinated for Marburg or Ebola viruses here. We have older people with comorbidities, very high risk of disease spread and mortality. So the actual spillover of the virus here, it occurs from the Egyptian russet bat. And these bats roost deep in caves. So you find that actually in the deep inside parts of the caves, you have large colonies of ERBs that are often the dominant colony. And then more proximal in the cave, you have other types of bats that are more insectivorous, at least in the areas that we're working in. CDC, who we are actually partnered with, the viral special pathogens team, has done extensive research here looking into the host. How is this host shedding? What causes the host to shed and what stresses the host? As Sheri mentioned, this is a big factor when you're talking about vector-borne transmission. So GPS tracking has shown that these bats actually fly up to 50 kilometers in a single night. So even if you're not living near a bat colony, you may be exposed. In many of the areas we're working in, people note bats coming to eat from the fruit trees, consuming fruit. And studies from the CDC have actually shown that where they infected a bat colony, they had the bat eat fruits, and then they looked at how long they could find live virus in the fruit thereafter, and it was for up to 6 hours. So this is a plausible mechanism of transmission. And what we know is that actually the peak shedding virus from the bats occurs in September and January, and these are birthing months for the bats. And so essentially what we saw was in September, there was an outbreak of Marburg in Rwanda. In January, there was an outbreak of Marburg in Tanzania. And many of the outbreaks have actually followed this pattern of when the bats are shedding virus. So if you think about spillover dynamics and climate change and how this may be affecting the reservoir host, broadly speaking, your reservoir host has to be present in the area that you're in. It has to be actually infected with virus and has to be shedding virus. So in terms of being present, there are studies showing that there's range expansion of the Egyptian russet bat into cities, into more populated areas due to changes in precipitation, temperature extremes, occurrence of droughts and fires. A study from South Africa showed migration of ERBs to residential areas, particularly during the dry winter season. Bats are very good in terms of being infected and not actually getting very sick. So they have very high immune tolerance to many pathogenic viruses. And so this makes them good reservoir hosts for these kind of infections. And in terms of shedding virus, so I mentioned to you that during the birthing season, that's when these bats tend to shed. But experimental studies from the CDC have shown that actually these bats they're super shedders. So there's some bats that shed a lot, and there's some that don't shed as much. So if you happen to come across bats that are shedding a lot, your risk of infection goes up by a lot. Now, the other part of spillover dynamics is actually your host. So your recipient host must be exposed to enough infection and must be susceptible such that they can get sick. So in the Colorado case, that the woman that got infected, she was on a tour of these caves. She was the only one that got infected, and she was the only one that actually touched a rock that had bat guano on it and then brought that near her face. Nobody else got infected, so she got exposed to enough of the inoculum. But host eradication is quite complicated. So there have been attempts to eradicate bat colonies that have actually backfired and increased the prevalence of infection in the colonies. This kind of reminded me of what the previous speaker was talking about in terms of the changing weather patterns and droughts, increasing some of this exposure to fungi. Here, what we see happen in the Kitaka mines. This is a mine in Uganda. So back in 2007, these mines are used for mining gold and minerals. There were 4 cases of Marburg virus disease with 1 death. So miners tried to exterminate these bat colonies against the recommendation of the CDC and the Uganda Wildlife Authority. Well, they succeeded temporarily, but in 2012, there actually was a larger outbreak of Marburg virus disease with 15 cases. And when they investigated, they looked at the phylogenetics of the virus, and they were able to trace this back to a colony of bats that had repopulated that cave. Now, this colony was much smaller than the previous one that was exterminated. It was only 1 to 5% of the size, but it had a 13.3% infection rate among bats compared to only 5% in the 2007 colony. So the hypothesis was that a bunch of susceptible bats repopulated the cave and more infection actually ended up spreading. So we're working in Mount Elgon, Kenya. I'll tell you a little bit about our study. Where basically in Mount Elgon, this is the border of Kenya and Uganda. There have been 2 cases of fatal Marburg disease in people that were visiting these areas. They were popular for tourists. And then 1 outbreak in Uganda among a farmer who actually was bringing his cattle up to get so that they could access some of the minerals and salt in the walls of the caves. These caves are actually also famous for elephants that come in to get access to these minerals and salts. People come in here to collect fertilizer and also for religious rituals, and they also were used during some ethnic conflict for being able to hide and kind of work out of the caves. I'll play a video so you can get a sense of what they look like. So they are massive overhangs. These are caves that go all the way across from Kenya to Uganda. And on the other side of this cave, actually, if you travel for many hours or actually even more than a day, as some people said, you get to the other side of the mountain where that outbreak happened in 2017. So we're doing a study right now looking at the seroprevalence of Marburg virus in people living in this area and understanding risk factors for testing positive for antibodies for populations that are in the area. We're doing a study looking at, we were hoping to sample at least 500 total residents. We've actually finished sampling. We sampled 536 residents across 6 pre-identified health centers. We use extensive community mobilization prior to enrollment days, where we kind of have some of our community health workers go out, let people know about the study. And then we do sampling where we have venipuncture done at the facility. Samples are centrifuged there and then transported to the county hospital. And then eventually they get stored at University of Nairobi, where my collaborators are based at. We also have questionnaires about demographics, high-risk exposures that people have, and their understanding of Marburg virus disease. And I won't get into too much detail, although I can answer in the Q&As, but the diagnostics we're using are a CDC whole cell ELISA, and then also a multiplex electrochemiluminescence platform that basically is similar to ELISA, but can test for many different antibodies to all kinds of zoonotic pathogens. And we're looking at basically how many people test positive for these antibodies. What do these antibodies, like how positive are they testing? Are these antibodies ones that can neutralize virus and can be used for therapeutic development? And then we're looking at all sort of risk factors for testing positive. But we have another study that we're planning now that's focused more on the climate angle of this, which is actually going to be looking at which caves actually have Egyptian roosette colonies. And then how are those colonies kind of moving through GPS tracking that we're planning to do. Where are they moving? How are they moving? And how does that relate to different aspects of climate, such as temperature, humidity, precipitation, and changing environmental factors? So far, I can report, at least from the questionnaire side of things, we have 44% of people said they had undiagnosed febrile illness in the past couple of years. 5% know someone that died suddenly of severe disease with fever. 36% reported encountering a bat in their home or workplace in the last 3 months. 44% reported entering a cave within the past year. And 38% of these people have gone deep into the cave where they can't see the front of the cave anymore. And 98% had never heard of Marburg virus before. So some of the future studies I mentioned actually really mapping out where these cave habitats are in Mount Elgon, understanding the effects of climate change on this, and doing environmental sampling of sort of different aspects of the habitat. And so I'll stop there and just say that, we have a massive team that we work with across the CDC, UC Davis, NIAID, and the Kenya USAID Emerging Threats Office. But thanks for listening and looking forward to questions.
Thank you so much, Dr. Karan, for that really interesting talk and work. I invite Dr. Heaney to turn on her camera for the Q&A session, and I'm going to invite you all to enter your questions in the Q&A. And as we are waiting for some, I'll just start maybe with a broader question for both of you, and then we'll go into the specific questions from the Q&A. So what innovations in early warning systems or environmental monitoring gives you the most hope for staying ahead of emerging pathogens? And maybe I'll start with you, Dr. Heaney, and then turn to Dr. Karan.
Sure. Thanks so much. And that was a great talk. So I think there are a bunch of sort of innovations and new things that are happening that make me more confident in our ability to have good early warning systems. Our modeling capabilities are improving really quickly with the development of sort of new methodologies, but also more computing power, of course. We're also better able to estimate past, current, and future environmental conditions better than ever, thanks to, again, those sort of evolving technologies and computer capabilities, but also more remote sensing data, being able to harness a lot more data to really get good estimates of environmental conditions at a fine scale. And I know that Dr. Karan is going to talk a little bit about environmental sort of monitoring. So what I really just want to focus on is sort of what I introduced at the end of my talk, which I think is sort of the most important aspect of this, which is to integrate all of these tools that we have as scientists into practice from the very beginning of our work. As scientists, we can do great work here on our computers and publishing papers. But if we're not really linked in with public health practitioners, healthcare providers, and communities from the beginning, then the work that we do isn't really going to have an impact. And so that's something that I have been really focusing on, and I think is a really important, unfortunately, innovation. There is a history of researchers sort of going into communities and being extractive. But I think what we really need to do moving forward in order to effectively adapt to climate change, which we all know is sort of here for the next at least 50 years. So we have to adapt now to protect our vulnerable communities. We need to really have those communications, mutual knowledge sharing, and work together with practitioners from the beginning of our research.
Thanks so much for that great response. And Dr. Karan.
Yeah, a couple of things that have really stood out to me, particularly during the H5N1 outbreak and also during COVID-19, is environmental surveillance and sampling utilizing wastewater technologies. Wastewater was particularly useful, I think, in the sense that it became very difficult to be testing at healthcare facilities that really depended on people coming in and doing testing. Where this actually played a huge role was that those systems that were developed during COVID-19 were actually leveraged for H5N1, and actually one of the first cases that was detected, or the first spillover events was detected during using a hybrid capture technology where they had basically passive monitoring of the wastewater for all kinds of pathogens, and they picked up H5N1 in Texas wastewater. And they picked it up way before we knew that this had started to spread in cattle, before we knew that it was starting to spill over into humans. And so there was a signal that was basically given. And as we saw during the outbreak, what happened was it became very difficult to test, right? Because the dairy industry, there was resistance, there was concerns from workers about privacy, and so we really relied on some of the environmental surveillance that could be done that wouldn't pinpoint and bring fault to somebody particularly, but still warned us that there was something going on with H5N1. Similarly, there's the Breathe program that was set up by the U.S. government, where there's a lot of innovation happening now for air sensing. And so this is particularly important because we know communicable disease spread is most efficient when you have airborne transmission. And so having sensors that can pick up airborne spread of pathogens from the environment, particularly in healthcare settings, but also in workplaces and airports and points of entry, is very important. And I think there's a lot of progress being made there. So those are two things that jump out at me.
Thank you so much. So I see a lot of great questions in the Q&A, and I'll start with one, I think, more for Alex, but feel free to jump in, Abraar, and then I'll go to one for you, Abraar. So Alex, what will you anticipate being the issues of increasing concern for the Central Valley?
I assume that is sort of outside of valley fever, maybe. I think the Central Valley, and I won't claim to be an expert on sort of all of the issues in that community by any means. I know that there are a lot of concerns about environmental exposures in communities in that region of our state. There are a lot, of course, of agricultural workers that are all outdoor workers, and as a result, just inherently more vulnerable to extreme heat, which is a big problem there. Into valley fever. I'm also have a lot of work looking into dust exposure. So looking at, windblown dust, sort of separate from valley fever, but related, and how that can impact outdoor worker and just everyone's health. So there are a lot of sort of things that are combining in the Central Valley to make it a really difficult place when it comes to environmental exposures. So I think, also water usage, all of these things are going to be important. And so what we have to do as scientists and in collaboration with communities and community-based organizations is to really think about what are the priorities for these communities, how can we sort of better understand what challenges they're facing, and then design interventions and help to build the resilience, which is really the key in the face of all of these environmental challenges.
Great. And I will just maybe add that all those pathways that I talked about, like food insecurity, water insecurity, loss of livelihoods, are very big concerns and important pathways towards increased infectious diseases in the Central Valley. So I'm going to ask Abraar, what other factors besides climate change were considered to study emerging infections? Is climate change the main factor or one of the contributing factors in
Well, I think climate change is one of the factors, but part of it's climate change. I think is broadly, there's so many other variables that get involved with this. So if you look at climate destruction, that is pushed forward by certain commercial industries, deforestation, any kind of habitat changes that are, one could say really man-made or man-driven, are pushing us towards getting closer to vectors, right? And so when you think about zoonotic spillover, most of the emerging infections that we see are zoonotic. They are being transmitted from animals into humans. And we've talked already about the fact that both changes in weather patterns, extreme weather events, those impact the host. These reservoir hosts get stressed and they shed more. But beyond that, how do humans and animals start interacting? It's as we get further into their into their habitats. So I think that there's many industries involved here. There's many incentives, financial incentives, and other incentives that drive these things. But I think broadly speaking, those are some of the key factors.
Yeah, no, that's a great point. I think all of the ways that we're encroaching on animal environments is a really big factor here. I also just wanted, someone asked, and I think I see it was answered, but how aware the ID physician community is on the connections between climate and health. And I know, Abraar, you answered that. I will just say that, I have been personally giving grand rounds on this topic to infectious disease departments the last few years. And there's a lot of work going on curricular development, not just for infectious disease, but really for all subspecialties. In fact, I'm part of the National Academy of Medicine Climate Collaborative, and this winter, uh, we're actually going to be hosting a session to try to come up with a framework for integrating climate change into all medical and health professional societies for very specific step-by-step ways on how we need to change both existing curricular for ongoing health professional students and also for continued learners like practicing physicians. So just back to Michelle's question. Michelle asks, it's difficult for farm workers to wear N95 masks during the heat. In addition, it may be difficult to close windows when at home. Is there any research occurring to create barriers against valley fever that are useful for this population?
Yeah, what an important question. It's easy enough for us to say wear an N95, but when you're out in 90, 100-degree weather and it's hard to breathe, I mean, it's so hard to wear those masks. If you don't have air conditioning at home, it's so hard to keep those windows closed. So I really appreciate that question because I think it gets to the reality of people's lives and how they interact with some of these pieces of advice that are given to them. At the most basic level, but I guess most foundational level, there is ongoing work trying to develop a vaccine for the valley fever fungus. That there are a lot of very smart, dedicated people working on that. We do not yet have a vaccine for humans, but I believe that, they will sort of continue to work towards that. So we can hope that that will be available sometime in the future. And that will, of course, be a really important tool to prevent disease in a lot of these populations where sort of that individual level prevention is just not really feasible. There are other ways that we can be creative in the meantime in terms of, thinking about sort of pairing early warning systems with some sort of change in work schedule or thinking about specific ways that people can sort of respond to the knowledge that there might be an increase in risk coming up and sort of reorganize their activities or their lives around that idea to try to avoid the dustiest conditions if possible. There are also ways, and I am also not an expert in this, but I do know a lot of my dust colleagues are sort of working on these different ways that you can actually mitigate dust emissions in these big sort of open bare land areas, including sort of creative ways of putting bales of hay around the ground. I saw an example study for that where if you put it in a certain pattern, it can actually decrease the emissions of dust, and we think maybe then also of these fungal spores. So there are ways that we can get creative, and I think that your point is very well taken and is an incredibly important aspect of exactly what I'm talking about, which is that we have to collaborate with communities and these people that are the most affected so that we can come up with strategies and communications that are the most useful for them.
Great.
I'll point out one thing on that actually also. So if you look at the H5N1 spillover that happened during the culling in Colorado, they weren't able to keep PPE on for the same thing, extreme conditions, extreme heat. And there's many innovations in the PPE space that actually can help here, and I think they're not getting to the workers that need them.
Great. And I see there is a comment about educating communities about the risk of zoonotic diseases, and that's really important. So I'll just, mention one word in the question about how the funding landscape is affecting research. And this is a very big concern, not only because climate change is sort of on the list of things that are to be, non-prioritized or defunded, but also because a lot of global health research, as many of you know, is under attack. And we're having to remove foreign subcomponents. So I am spending a large proportion of my time trying to figure out how to get the foreign subcomponents through a domestic NGO. It's very disruptive. And I think it'll be very hard to do this research in these most impacted communities. where people are disproportionately impacted from climate health impacts. So that gap that I showed you earlier in low and middle income countries is only going to increase by this issue of NIH funding. So in the last minute, first of all, I want to take a moment to thank our wonderful speakers for your great insights today, and thank the audience for your questions and interest in the topic. And I just want to remind people that we'll be sharing the recording with registrants. So you could find this recording and as well as recordings of all of our prior webinars at the link in the chat. And we will also try to post answers to the Q&As there as well. And so with that note, I will say thank you and have a very nice day, everyone. Thank you very much.